Hello, this is Coach Gogo. I am here with Dr. Nkirika Erekosima at Alpha Allergy and Asthma in Silver Spring as part of our continuing series to educate you on some of the things you might be concerned about, either if you're allergic, asthmatic, or a parent or caregiver of those battling with allergies and asthma and related conditions. So we're here today to talk about, we're approaching the end of the year, so we want to talk about the aspects of care related to your insurance plans and how that may relate to some of the decisions that you make at this time of the year and in preparation for the next season. So, Doctor, thank you for being here with us. I appreciate the time you've set aside for this, and good to see you on a personal note.
Sure, it's my pleasure.
All right, so I want to ask you a question about this, just the deductibles and how those might relate to what you hear from from some of your patient community at this time of the year. How do we think about our benefits? And some people have maybe met their deductibles. What should they think about doing at this time?
So, in order to answer that question, I think it helps to just address the issue of what is the deductible. Right. In recent years, the types of health insurance plans that we're seeing, it's really changed in recent years, and we're seeing more high deductible plans. And so really what that deductible means is that your insurance company will assign an amount that they call the deductible, and that amount is the amount that the patient has to pay for some services before the insurance will start providing coverage for it. And so it doesn't apply to all services. Really, it's the insurance company that determines which services the deductible will apply to. Okay. Now, as an allergist immunologist, I see a lot of patients with those types of plans, and they will apply some of the allergy services to the deductible, such as allergy skin testing, allergy shots. Those are some of the more common ones that we see that they apply to the deductible. And what it means is that they set an amount. So for example, some of the lowest deductibles that I've seen are around $350 approximately. But they will set that deductible. It could be $350, it could be $1,000. And what they tell the patient, or what they also tell the doctor's practice, is that the patient is responsible for up to the amount of the deductible. So if it's $350, you are responsible for up to $350. And after you have paid for that service, up to $350, whatever is left, the insurance will then start paying for the difference.
Okay, so briefly, right? Take me through the way that most patients approach this. Assuming in our example that the start of their health insurance year is January, so it was January 2019 or January at the start of the year, then how does it flow out? Do the patients just pay their deductibles at the start of the year so they don't have to deal with it? What do most patients do?
So from the start of your plan year, most insurance plans start on January 1st and end on December 31st of the year. Okay. And so over the course of that 12-month period from start to end of your insurance plan year, they start to count the deductible. So they start to determine which services apply to the deductible, and they keep track of how much you have paid towards the deductible.
Okay.
So
Okay.
you could see one doctor, you could see, for example, an ENT doctor, and then you pay some of your deductible, and then next month you see the allergist, and you pay some of your deductible, and the next month you see your primary care doctor, you pay some of the deductible, and it just continues to add up. Once you hit that maximum deductible amount that they've set for you, the insurance then starts to pay for everything above and beyond that deductible amount, because they now see that you have satisfied the deductible, which they typically will say you have met the deductible. And so now they provide coverage for the services, the charges that are billed above and beyond the deductible amount.
Okay, so that would seem to imply that as we approach the end of the year, we might have some members of your community that are like, hey, I've met my deductible. This might be a good time to get some things done that have probably been pushed up from a cost standpoint.
Yes. So, and that happens around this time of the year. We often see patients who have met their deductibles, and they may have put off a lot of their allergy testing earlier in the year because the upfront cost in terms of paying towards the deductible would have been high at that time. So after they've met their deductible, it's a good time to come in and get the testing done. So we see that happen with those who need allergy testing for environmental allergies, for asthma, for food allergies, for penicillin allergy, or any kind of drug allergy testing. Okay. We also see it for people who need allergy shots. Okay. And if those services apply to their deductible, they often will come in towards the end of the year and tell the doctor, I am ready to start now. I met my deductibles, so I think the cost is going to be a little bit easier for me to handle at this point. And that's the type of conversation that happens towards the end of the year.
Okay. And with this season, are people also are they making other considerations and coming in? Because we talked a little bit about this. The scheduling. Let's take the allergy shots for instance. You mentioned an accelerated schedule. How does that work relative to this end of year decision making, so to speak?
So when someone starts allergy shots, they have to build up to what we call the maintenance dose. Okay. And that maintenance dose is your true effective dose.
What does that mean?
What that means is that when you're on allergy shots, we're supposed to get you on a dose that actually gets your allergy symptoms under control. And that's what your effective dose or maintenance dose is. Okay. Now, we can't give you that maintenance dose on the first injection because your allergy shot contains the things that you're allergic to. If we gave you a full maintenance dose on your first injection, you would have a severe allergic reaction. And so the way to do allergy shots correctly is to start with a very low dose, a very dilute dose, and gradually you build up to that maintenance dose. And over time, the building up allows your body to become less sensitive to what you're allergic to and less sensitive to the allergy shot solution so that you can eventually tolerate your maintenance dose. That's the whole goal.
I see.
That's the whole goal of the build-up process. Now, building up, that build-up phase of your allergy shot treatment takes months. And so it would take you months from your first injection to get to the maintenance dose from your first injection will take months, is what I mean. And so
it will typically take months.
Typically, yes, it will take months. Now, there are accelerated schedules that will allow you get multiple injections in one day. And what that does is it helps you build up to that maintenance dose faster. Now, keep in mind that for several of the individuals that we see who have allergies and need to be on allergy shots,
Mm-hmm.
they need to try to get to that maintenance dose by the time their peak allergy season comes around. And for a lot of people, that peak allergy season is the pollen season, so like starting in the spring. And so sometimes there's just a short window to try to build up to your maintenance dose before the spring hits again, and the pollens will come out again. And so having an accelerated schedule is very beneficial because it helps people get to that maintenance dose faster. And so for those who have met their deductible and they want to do that in an accelerated manner, we have that accelerated schedule that we call cluster immunotherapy. And that is a procedure that can help people get to their maintenance dose as quickly as within 6 weeks. So instead of taking months, we can get to the maintenance dose within about 6 weeks.
Okay. Let's go back to something you mentioned very briefly a bit earlier. You mentioned penicillin allergy testing.
Yes.
Just cover it a little. Just tell me more about that. In what context does it come up? Like who might need to get that procedure? Who might need to come in for that?
Sure. So penicillin allergy is one of the most common drug allergies that we see people report. And usually it's a history of a penicillin allergy. The patient might not even remember or recall any the event or any of the symptoms that they had, because many people had it during like their early childhood and they were told you have a penicillin allergy, and so they avoid penicillins. Now, what we know is that majority of people who have been told that they have a penicillin allergy or had an allergic reaction to penicillin at some point in their life, majority of them have lost that allergy after 10 years. And penicillin is one of the best medicines that we have. Penicillin allergy also leads to avoidance of medicines that are related to penicillin, are in the same family as penicillin. And so when people report a history of penicillin allergy, they're really avoiding several antibiotics in that family. And it's really a goal, and the CDC actually has information out on this, indicating that we really should be testing the individuals that report a history of penicillin allergy, because majority of them will have negative allergy testing. And so majority of them truly no longer have the penicillin allergy. And what that does is it opens up antibiotic options for them should they become sick and need an antibiotic. They have access now to very good antibiotics, because penicillin and the medicines in the penicillin family are very good antibiotics that we want to have available should anyone need it. So for that reason, we do penicillin allergy skin testing, and we can effectively rule out a penicillin allergy in someone who no longer has the allergy.
I see. I get it as far as the antibiotics and the importance. I'm just trying to figure out, are there everyday scenarios where where this is a problem? Why is the CDC bringing it? So for instance,
yeah.
Okay. I mean,
I think I understand what you mean. So let's take, for example, some of the most common infections that we see: sinus infections, ear infections, respiratory infection, other respiratory infections.
Okay.
Some of the more common antibiotics that will be chosen will be the penicillin family. And if someone reports a history of penicillin allergy, the doctor would then avoid penicillin and will choose another antibiotic that may not be the best choice for the patient. Penicillin and the medicines in the penicillin family are usually the first line of treatment for many common infections. And that's really why it's important to rule out penicillin allergy if you have been told before that you have it.
Okay,
it's really important to get that testing.
Okay,
done.
well, I just want to push back on this a little bit, like in terms of the like the so what. Okay, so what if I don't? What if I don't get to have the first line of the, why don't we go to the second line? Like, what's the cost of? What's the problem?
I think that's a very good question. So the problem, if you don't have the first line of treatment, is you choose another antibiotic that is an alternative to the first line of treatment, but might have other disadvantages. So for example, the antibiotics, penicillin is considered a narrow spectrum medicine for some infections, meaning that it would take care of the infection that you have right now, but it's not going to so to speak, like knock out some of the other bacteria that we need you to have. But when you take that we need your body to have to keep right now. So when you take some of the other alternatives, they're broader spectrum antibiotics, and the broader spectrum antibiotics have the disadvantage of kind of wiping out more bacteria than we want to. So we want to kind of stick with the antibiotic that focuses on the infection that we want it to take care of while not affecting other bacteria. So we really don't want to have to do the broader spectrum antibiotics if there's no need to.
Makes sense. Okay, wonderful. Okay, thank you very much. So I thank you again for jumping on this call. We're going to try to pick up on, on this series in the coming weeks, as we approach, certainly as we approach the spring allergy season, but also heading into the turn of the year. So I appreciate the time you're taking, and look forward to another call again.
All right. Well, thank you.
All right.